Okay, so today we're going to review the pharmacology for heart failure. Quite a few background objectives. Your ability to understand these drugs and the pathophysiology and even the physiology is really going to be centered upon being able to define some of these terms. A lot of this background objective material is really covered in physiology, and some of it is covered in pharmacology. And where appropriate, we'll define these terms as we go along. But because of where this is falling in the curriculum, at this point, you would have seen almost all of these terms, but this is just kind of a quick reminder in terms of what you need to be aware of for the next group of cases going forward. These are the session objectives. We're really going to focus on all of these different drug classes and how they relate to the treatment and correcting pathophysiology of heart failure. Okay, so here's the drug list, and what I've done is I've matched the drug category with kind of their immediate change to physiology and how that change to physiology matches with correcting the pathophysiology that you're learning about in other disciplines or other modules. And so, beta blockers are going to basically inhibit the ability of calcium, which is going to affect contractility, and that is going to indirectly reduce cardiac output. And that cardiac output that needs to be reduced is becoming active from essentially sympathetic nervous system stimulation. So these are the outcomes to sympathetic nerve stimulation. And so, if you come back to this particular chart, this will kind of make sense when you put everything together. And so here you've got kind of the introduction to the different drug classes, and these are color-coded. So the drug classes on the left kind of match with the pathophysiology outcome on the right. And so both vasodilators and calcium inhibiting drugs like beta blockers are going to have activity on the sympathetic nerve system. Drugs that target the RAAS, or the renin-angiotensin-aldosterone system, such as ACE inhibitors and ARBs, or angiotensin receptor antagonists, those are going to have their main effect on the renal perfusion status. And of course, diuretics, while having their mechanism here on the kidney, also kind of control this pathophysiological process of volume overload. Okay, and so all these factors kind of contribute to the pathophysiology of heart failure, which we'll examine in a little bit of brief detail in terms of review. So what is heart failure? Well, essentially it's damage to the heart. Okay, and so this damage can be myocardial infarct, so a specific ischemic event, or this could be long-standing hypertension that's either ineffectively controlled by drugs, or the patient maybe is non-compliant. A whole host of factors can kind of produce that. But the main outcome here is that at the end of the day, you have a reduction in the efficiency of cardiac pumping. And so the way we measure that is cardiac output. And so in heart failure patients, we have a defined set of criteria. And if you are below that set of criteria, you are classified as heart failure. Okay. And so cardiac output, remember, is determined by such physical forces as preload and afterload, which were defined in physiology, contractility, as well as heart rate. Okay, so what does that mean? So if you've got reduced cardiac output, you're going to have reduced cardiac or systemic perfusion. And so here you have, global reduced oxygen perfusion, not only to the heart, of course, but also to all tissues. And so in response to that, there's a compensatory change by those tissues, namely the lungs and the kidneys, to restore perfusion. Okay, and so these compensatory changes actually progress the pathophysiology of heart failure. Okay, so those compensatory changes, what do they look like? Of course, it's going to be mainly demonstrated by tachycardia. All right, and so here we're going to see increased contractility because we're going to have persistent sympathetic nervous system stimulation or activation. The patients are going to present with fluid retention or edema, and this is coming from the fact that poor cardiac perfusion or poor cardiac pumping is going to result in poor renal perfusion, and that's going to activate that renin-angiotensin-aldosterone system. Okay, and then of course there's going to be a vasoconstrictor response, and that's going to increase our afterload. In the damaged heart, there may be ventricular hypertrophy. There might even be some remodeling in terms of the matrix proteins that make up the ventricular muscle. And you may even see D-type natriuretic peptides being released. And so, these are all the compensatory changes that occur in a patient who's experiencing heart failure. And so all of these compensatory changes then, therefore, can become pharmacologic targets. And that's, of course, kind of the introduction to our pharmacology. So understand that reduced cardiac output is going to obviously be evident by reduced carotid sinus firing, as well as reduced renal blood flow. And so these processes, which I really like, these are summarized in the pharmacology textbook, are really going to have direct effects on the heart. And here you can see ventricular remodeling caused by excess of angiotensin II, as well as an increase in afterload. The sympathetic discharge that's coming from secreted norepinephrine is really going to affect preload, rate, and the force of those contractions, which is going to try to restore or increase cardiac output, and those compensatory changes is really kind of what drives this process. Now understand that over time, cardiac performance is going to be diminished because as these compensatory changes occur, all right, the strength or the ability of the heart to be an efficient pump is going to be severely diminished. And this is kind of what this diagram hints at, is that, over time you have, these compensatory responses that try to restore cardiac output over time actually end up driving it further down. Okay, and so in the short term, these compensatory responses are perfect. They do the job, but over time they actually lead to more damage. And so it's kind of like a vicious cycle. There's two different staging classifications that are used in the clinic. One staging criteria is from the American College of Cardiology Foundation, and who have paired up with the American Heart Association. And so they have a 4-stage system, stage A, B, C, and D. And the clinical picture of what these patients look like is described in each stage. Okay, we'll spend more time on this a little bit later. This is in contrast to the New York Heart Association, which has a classification system based on class, and it goes class 1, 2, 3, and 4. Some diagrams will have a pre-failure or a class 0, and that makes more sense when you look at both of these two classification schemes next to each other. Oftentimes you'll see class 2 and 3 kind of combined because it talks about exertion based on physical activity and whether or not that physical activity is mild in class 2 or moderate in class 3. And so that's somewhat subjective based on the patient. Okay, so that's kind of a brief introduction to kind of the pathophysiology of heart failure, trying to tie in the pathophysiology compensatory mechanisms that were discussed in the other discipline with the intention of producing all of these as pharmacologic targets. Okay, so now the next video is going to focus on the first class of drugs, the vasodilators.